afternoon, Ninjas, and welcome to today's session, how to get the most out of your occupational health referrals. My name is Martin Hughes, and I've worked in the occupational health industry now for more than 15 years and currently manage the partnerships here at Medigold Health, where I work as part of the team that supports the HR Ninja community on a daily basis. If you ever need any support or have any questions in relation to occupational health, then please do not hesitate at all to drop me a message, get in touch via Facebook or LinkedIn. And if I can't answer it myself, then it won't take me long to find somebody who can provide the information or the answers that you're after. In relation to today's session, with the demand for absence management referral services increasing, we thought it would be the perfect time for us to host a webinar focused on getting the most and maximising the value of occupational health referrals that you make. Over the next hour, my colleague Nicky will give you an insightful introduction or a very helpful refresher on effective absence management, when you should be engaging with occupational health, and what makes a good referral, which I hope you'll find interesting and useful. Your host today, Nicky Piper, joined Medigold in 2019 and is now our Deputy Chief Nursing Officer. Nicky has been working in occupational health for more than 20 years, from helping troops on the ground in the aftermath of 9/11 to resuscitating a fellow spectator at a Charlton Athletic football match. Nicky has had an exciting, eclectic and emotional career in nursing, which has literally taken all around the world. There isn't much that Nicky doesn't know about occupational health and management referrals, so I'm confident that you're in pretty safe hands with her for the next hour. As with all of our webinars, today's session is going to be recorded, and each of you will receive a follow-up email which will include a link to the recording in a few days' time. Please also use the Q&A function in the panel of Zoom to ask any questions, and then Nicky will do her best to answer as many of these as she can at the end of the discussion today. Our clinically webinars are very popular, and we run these regularly throughout the year. So please keep an eye on the Ninjas page and our other social media channels for updates on when these will be taking place. There's also lots more information on our YouTube channel and in our podcasts, which are available in the usual places. I hope that you all enjoyed today's session and look forward to connecting with you more throughout 2020. Nicky, over to you, and I'll try and drive the slides the best I can for you.
Thank you. Thanks, Martin. That was a big introduction. I just hope I can keep up with that kind of size that you've just introduced me as. So hi, everyone, and welcome. As Martin said, we're going to do a bit of a tour through what makes a good occupational health referral. I've put a couple of slides in there just to make us think a little bit, hopefully, but hopefully you'll find this session useful. Thank you. Ready for my next slide, Martin, when you are. Thank you. So I thought I'd just start off this session with the role of occupational health, and apologies for my phone ringing in the background. That's the house phone. It never rings normally. So I thought I'd start off with the role of occupational health and kind of where we fit in, really. And I think this slide kind of demonstrates the key reasons of our role. We're there to support managers and to help make good decisions when they're trying to progress a case. We're there to provide advice to enable safe, timely returns to the workplace. The key thing for me, though, is that we work with yourselves in a partnership type environment, because this allows us to grow, develop and understand each other, and we're there to help you reduce your attendance and reduce your sickness absence even within your organisation. But we can't do that alone. We have to do that working alongside you. We're here to support managers to be confident in taking action. So when we write those reports back to you, the actions that we put in there, if managers are struggling, we're there to help them and get them through that process as and when required. We're there to provide a report with a professional opinion, and I think that's the key thing. We're giving you our professional medical opinion, and sometimes, as I'm sure you've experienced in the past, not everyone likes our opinion sometimes, but we're there to kind of help confirm and understand what that opinion's about and why we've made that decision. We're there to be objective, to offer you a solution to a potential challenge that an individual has in regards to their health too. Thanks, Martin. There are a few things that we can't do, and as much as we'd like to, it's just not appropriate or right. We can't manage your sickness, absence, or performance alone, but we can certainly help with you, help you to manage that in a partnership type perspective. We can't tell managers what to do either. Occupational Health can only ever offer advice to managers, and it's up to them, the business and the manager, to decide if it's something that can be accommodated or cannot be accommodated. We can't disclose medical information that's not relevant. Obviously, if the individual's been very open, transparent, and has told you all about their illnesses, then clearly that'll be in the referral and it's easier to talk about. But if they have decided that they don't wish to disclose everything to you as a manager, but have given us some more information, it's our job to make sure you understand what this person's restrictions or limitations might be, and then you as a business can look at whether you can support that. So we won't be able to disclose that without the consent of the individual. We also don't provide a diagnosis. This is obviously something that a GP or a specialist is there to do, and we can't do a diagnosis or do any extra tests. We will probably have a reasonable idea of what the problem is that the individual's experiencing, but as I say, we can't give that actual diagnosis and prescribe treatment for that. And we can't act without informed consent. So I'll just spend a couple of seconds about consent. So obviously, whenever we submit an occupational health referral, we get the consent of the individual. At any point during that full process, from submission of referral till release of report, the individual has a right to withdraw their consent at any time. If this happens, we certainly try our best to encourage them not to withdraw their consent, because it's in their best interest to work with you to get the best outcome. But clearly, if someone decides that they don't wish to continue, then we have to respect that, and we would inform you if that is the situation. Thanks, Martin. So just a little conundrum here. Is an OH referral really appropriate in all of these environments? I think in answer to that question, there are certain things within this slide, unpaid leave, for example, training need, that shouldn't really fall under the remit of an occupational health referral. They're mainly things that can be managed by a manager and probably with yourselves in HR to actually conclude on some of those points. If someone's asking for a flexible rota or flexibility around career breaks, etc., these are really management-based issues. So shouldn't really cross the path of occupational health unless there's a predominant medical concern within that. Then you may wish to refer those in, but as a rule, they can probably be managed outside. Most organisations have quite a robust attendance management policy, and those where we've got short-term frequent absences, they're certainly good to refer into occupational health, because what we can offer you there is whether there's an underlying long-term health condition that you should be considering under the Equalities Act, or whether this person's just having opportunistic infections, and that's why they're off work. So normal process and policy procedures would still apply in that situation. Equally, if someone has got an underlying medical condition and it would fall under the Equalities Act, there's still robust policies that can be followed if that person's absence is of a high nature and you've put in place all the reasonable adjustments that may be appropriate and right and can be accommodated. General health problems, if you're just seeking a little bit of advice about any reasonable adjustments, or correct and the right reason to refer. Problems outside of work, again, if you've got things like EAP and those kind of support systems within your organisation, that might be the first level of call for that before you then refer in if it's having an impact on their ability to do their job. Career development needs, again, probably should not be referred in unless there's something that you feel is obstructing, like an ill health issue that is perhaps causing them to have more time off sick, and you need some advice around reasonable adjustments to encourage and develop them, then yes, that would be appropriate. But in the first instance, at face value, it would be a managerial discussion and resolution. Thanks, Martin. So I just popped this in to say, how quickly should you refer to occupational health? And I've kind of broke them down into the 4 categories. I know there are other things that fall outside these, but I just thought these would be quite a useful rule of thumb. So I think in the mental health cases, early referral is really important. And submitting that referral early will encourage early intervention, because I think one of the key issues often with mental health is people sit and hope that it'll get better by itself. But in reality, the likelihood is they'll need some intervention and support. The sooner you can get that intervention and support, then the better and the quicker the recovery and the return to work is likely to be. I'm sure you've all seen statistics that if people are off for more than 6 weeks, the likelihood of return to work is dramatically reduced. So that's where the key for early intervention comes in, and to ensure that they get everything that they need at the earliest opportunity. Sometimes individuals feel that they don't need it, and it's about having a bit of an open discussion with them to suggest why it might be useful to them. Planned surgery or emergency surgery. Some people refer prior to the operation, which is okay, but what you're going to get is, providing everything goes well with the surgery, this is the expected time frame for recovery. This is the expected time frame that this person will need out of the workplace. It's often better to refer once they've had the surgery, because then we'll be aware of whether their surgery went as per plan, or whether there were any complications or anything further that might be required in that. So it's probably better to just hold on until they've had that procedure and then refer them in for the advice and guidance. MSK injury or musculoskeletal injury. Again, good to get an early referral in, but preferably once they've got the diagnosis, or if you have physiotherapy services that you can refer directly into at the point as soon as someone's injured, then utilising those services as quickly and efficiently as possible is a really good use. And then obviously once they've kind of had their diagnosis and they're in their treatment plan, if you need some further occupational health advice, then that's a good time to refer those in. General illness. Now, this is quite a difficult one to kind of categorise, to be fair. And I think, you know, where people are still going through some investigations or are acutely ill or in hospital, probably not worth referring them in until they've been discharged from hospital, when there's at least some background history as to type of tests they've had done, the kind of immediacy of the results, because then we'll have a bit of a picture of what's likely to be the time frames and support required. I think if they're referred whilst in hospital, it's a bit too soon for us to actually be able to then offer you anything constructive thereafter. Thanks, Martin. So I just popped this slide in as a point of thought, really. So the topic of work-related stress is very common, and I'm sure you all have had incidences. So my kind of thoughts to you were, should work-related stress be referred directly to occupational health? So there are two sides to this, in my opinion, and you know, in the questions, please feel free to kind of come and challenge back on this. I feel that work-related stress, when it's first detected, should certainly be controlled by manager or within the business itself. So we all know that early intervention for any work-related stresses will respond with a positive outcome. What's really good to have in place, if you haven't already, is a stress management program or a stress management policy, with then the ability for your managers to put into place a stress risk assessment for anyone who's saying that they've got work-related stress. The sooner this is done, the better. And getting that in place, putting in some adjustments for them to try and help and support them may well keep them at work. If they've gone off sick, certainly don't hold back. Please do those stress risk assessments, because that's going to then assist with any blockers that the individual might be putting in place as to why they can't come back to work. And when if you get to a point where you've looked at mediation, you've looked at everything within your remit to resolve the problem, if there's a health issue behind it, then it's the right time to refer to occupational health. But what I would do, if that's the case, is just make sure that you've included in that referral everything you have done as a manager towards trying to resolve this situation. So that's my opinion on work-related stress. Majority of them should be, or conflict is often the causation of the stressor. Then most of that can probably be resolved by yourselves within the business, but only in rare occasions would you need the input from occupational health. Thanks, Martin. So just moving on then, so you've made a decision that this person needs to be referred. So prior to the referral, there's a few things that help that referral run smoothly. And I think I always look at a referral as two sides to a story. So putting the referral together is your side of the story from a business perspective. And then we meet with the individual, be it via Zoom, be it face-to-face, on whatever level for that consultation. So we then get their side of the story. So I think it's really important when you do that referral to be very clear about what you want to gain from this referral. And sometimes I think this is where things fall down in the referral process. So it's about being very clear about what you want to gain. Again, being transparent with the individual just makes this a much smoother process, because they understand that the reason that they're doing this referral is to support them. And it's good to show them that referral, because all of these documents are disclosable. So discuss the referral with the employee and also give them a copy of that referral so that they know what's coming when it comes to the consultation. Some of the challenges that happen where they've not had that input, it's often quite difficult for the practitioner then to build that rapport and openness with the individual, because they're having to go through what's in the referral. So that's really key for me, and it will give a smoother passage through for the whole consultation. Take your time to complete that referral, be it online or in paper, whatever you practice, and make sure that all the relevant information's attached, because what we don't want to do, and what we know will irritate you, is regurgitate things that you've already done. So just make sure in that referral, if you've done a stress risk assessment, you make sure you mention that, attach it, so that any other suggestions can be provided to you if we've got any. If you've kind of made adjustments to their work environment, took some parts of their role off them, please just make sure that is all very clear in the referral. And then when we write back to you, we'll be looking at what you can do next, rather than regurgitating what we think you might have done or might not have done. So that's really key for me, and we'll get you a better outcome at the other end. And then before you submit it, just have a quick read through and just make sure that all the information is in there, all the information's correct, like phone numbers and stuff like that, because that's another thing that might slow the process down. Thanks, Mike. As it says on the little post-it note, remember, what you put in is what you'll get out of that referral. So, as I've said, ensure all the information in the referral is accurate. what actions have already been taken. This is just a kind of quick refresh, and what contacts been made during their time off. Have you had a good open relationship with them, or has communication been difficult? It's just good to understand what's been going on in the background. Any rehabilitation or adjustments that you've already put forward. So if you've referred them to EAP, please state that you've given them the information to refer to themselves to the EAP. Just make sure that's all in there. And I think if there's a key area in the person's role or concern, then make sure that's highlighted too within the context. So if there's one element of their job that they're really struggling with, then just make sure that's known to the practitioner, so that they can try and kind of pull that around a little bit and look what opportunities there might be or not. I think the key thing on this slide is, what's your view of the situation? Now, I appreciate and understand it's quite hard to be absolutely 100% open with what your view is, but it would be really helpful for the practitioner to understand where you're coming from, because you'll have lived and worked with this person for a given period of time. You'll know their idiosyncrasies. You'll also know some of their behaviours. So it's quite useful to try and put that information across to us, obviously in a professional way that won't get you into trouble, but will help us to understand the kind of challenges that you're perhaps having. And I think about what questions you'd like to ask within the context of that referral. I'm going to move on to questions shortly anyway, and we'll just talk a little bit more around that. So as I said, quality in will hopefully give you the quality you're looking for on the other side. Thanks, Martin. So I think asking the right questions on your referral is really key. And what we find often is we allow 14 questions within our remit. Not everyone allows that many, but we give the opportunity of 14 questions. And what I've found is when you give people 14, they'll probably use 14. What I would say is you'll get much more quality if you ask 6 or 7, which I would think is a reasonable amount to be able to give you what you need. Bearing in mind, some jobs do have specific questions that you will want to ask. So we've put some examples in here of what key questions might look like for you. I think one question that is often asked, but I struggle to see the relevance from a managerial perspective, is what medication is the individual taking? For me, it's not about the medication, it's about the impact of that medication on a person's job. That should be the question that's being asked from a managerial perspective, because lots of people can be on lots of different medication, and unless you're a pharmacist or a doctor and work in that environment, it's not going to really mean a huge amount to you. But knowing what the impact of that medication can have on that individual versus the type of job they do is a real key factor for me. Because if somebody's in a safety critical environment, you need them to be in tip-top condition. So if their medication's making them sleepy, they're probably not going to be safe to do that safety critical job. So that's a real key question for me in those high risk environments. So there's quite a lot in there. Obviously, there's the question around, will this person be covered by the Equality Act? And we do have a standard response to that, because ultimately the decision is a legal one. However, we can give you our medical opinion as to whether we feel that person is likely to be covered by the Equality Act or is unlikely. And with that information, as a business, you can then decide what reasonable adjustments you are able to support, taking into consideration that that might be an equality requirement. I mean, most businesses these days tend to take everyone at face value and do as much as they can, whether they fall under the Equality Act or not. But when we get down into those kind of tight niche elements of those tricky cases, that's a real relevant question to ask. Asking if the person's having the correct treatment that we believe is a good question, because if we feel that they're not doing all they can, we can respond within that context that the individuals, we've sent this individual back to their GP as we feel that they may need change of direction of treatment or medication or whatever that might look like. So choose your questions very, very carefully, because for me, that kind of is a real key aspect of what you're going to get back. If you don't put any questions, from a Medigold health perspective, we try and anticipate what questions might be useful to you, but in another environment, that may not be the case. So really important you put some questions in there, otherwise you'll just get some bland information back. Thanks, Martin. So I guess that's covered the main content of how to get the best from your referral, and hopefully I've given you a little bit of food for thought along that journey. But I think just to kind of recap before we go on to the questions, I think to make the whole process work well, I think it's important you're very transparent with the individual. They understand the reason for that referral. When you've done all your work at the first stages prior to submitting the referral, incorporate everything into that referral so that then the practitioner can see how hard you've worked to try and resolve this and can then offer anything additional. Or there may be situations where we can't offer anything else. And that then at least gives you an understanding that you've done everything you can. And if this person still isn't able to fulfill the job that they're employed to do, then that gives you your other opportunities in relation to the various policies on capability, etc., that you have. I think, getting all that information up front into the referral is really key. Once the consultation takes place, obviously the individual will give their kind of account of their own health and what actions they've taken. And then obviously the report is produced at the end that comes back to you. And within that, you'll get a summary of what's gone on. And there is some elements of he said, she said, because that's kind of just accounting for that consultation. But the real nub of things that will help you and guide you is in the conclusion element and the answer to the questions. And our suggestion is once that consultation's over, the individual will either get a copy at the same time as you receive a copy of the report, or may well ask to see it up front, which again is part of their rights under the GMC guidance. Then sit down with that individual, have a conversation with them about what's been suggested. Again, all of the reports that we produce say these are recommendations only, and it's up to management to decide if it's something that they can accommodate or not. Have that conversation. If there's any ambiguity in the report, please don't be afraid to challenge that, because the practitioners will have all had to justify their decision making when completing that report. So, please challenge it, and challenge it the sooner the better, because the freshness of that will be more helpful than perhaps leaving it a couple of months and then coming back and challenging the situation. Don't save them up, do it on a case by case, and then we can obviously look at making sure that you get that clarity that you require. Okay, so that's kind of the top tips from me. Any questions out there?
Nicky, there's a couple in, if you look in the Q&A.
Yeah, just navigate. Yep, okay. So the first one, thank you, is from Michelle Hunter. What about those who state work-related stress, I can't even read now, work-related stress, yet have not highlighted this? whilst in work but have gone off sick. So in those situations, you know, you would like to hope that the manager is having an open, transparent conversation with them. If there's an issue with the manager, then, you know, policies usually give a secondary person that person can approach to express what the problem is. It's unusual that it comes to light only when they've had an OH referral, but if they're not opening up or not prepared to, then I appreciate a referral may well be the only option you've got. What may come back on the back of that is that, you know, management need to resolve this with either a mediation or look at a stress risk assessment or words to that effect. So that would be what my suggestion would be in resolving those kind of things. But usually people don't just disappear off the face of the earth. There's usually something that's built up prior to. But if they do, then I would suggest that you might want to submit a referral if you really don't know what the causation is and the person's not responding to that. Okay, oh, sorry, second one from Michelle. We have a long-term anxiety and depression, 2 cases, reviews done and is resistant to both consent for the doc's report and OH, every reason under the sun. Then in that situation, if you've done all the kind of encouragement, openness, and explain to them, you know, why you want to pursue and get that information, if the individuals are not participating, then you know, over to you. You can only work on the information you have. And if they're off long term, you can certainly look at the capability side, because you've done everything you can to try and support that person every way possible. But if they're not participating in getting themselves better or that opportunity to return to work, then basically, you know, you can work on the information you've got and the information you've got only. Then you'll probably find once you start that process that they'll then allow you to do some of the things that you've been trying to do with them. It is common in anxiety and depression, as I think I said at the slide around when to refer, that people get into a bit of a cycle, and it doesn't matter how hard you try or how much support you try and give them, some people don't always respond, and sometimes it takes it till the 12th hour to get to that point where they realise the seriousness and the amount of that's required for you to work with them. Not an easy one, but it is basically down to you to then take them down that route. Okay, this is a longer one, so bear with me. We've conducted a fitness to work assessment whereby Occ Health has requested a referral is carried out. Upon inquiring with Occ Health what the diagnosis is, we've been told they are unable to disclose. How can we refer the individual and ask questions about reasonable adjustments without knowing this information? We've spoken with the employee and they have said they have a long-term condition. Oh, sorry, goes off my page, bear with me. And that it's self-managed, so don't need a referral. What should the organisation do? Okay, I think there's a couple of things here. No, we can't provide you with the diagnosis if the individual doesn't wish to share that. And you can actually write that you're asking in the referral, if you get to that point, that the individual is not happy to disclose to you what the problem is, but, you know, would we be able to help with any support or guidance in regards to that condition if they're not performing well in the workplace? If the individual states they don't wish to be referred, I think it's really important that you document that and they understand the repercussions of not having that if there's a problem with their performance and work. And I think never, you know, they can always be referred at any other time. But if they're absolutely adamant that they don't need anything, they don't need a referral, that should be documented, and you can again only work on the information that you have to help resolve that problem. So if performance is a problem in that case, which I suspect is possibly the situation, then you can just address that performance with them like you would with anyone else. And without the understanding of what the condition is and what the impact of that condition on their job is, you can't make any other adjustments for them because you've got no guidance or information from a specialist if they're not prepared to share that information with you. Did that make sense on all those answers? Was there anything else that cropped up?
There is another question that's I've just popped in there as well.
Okay. Okay. So can you all see these questions, or do I need to read them out?
I don't think they can see them.
Okay, I just didn't want to be reading them and boring people if they could see them. So, okay, that's no problem.
Yeah, if you read it, it will also be good for the recording as well.
No problem. So how OH specialists assess the information provided by colleagues and HR, on which basis OH makes recommendations, colleagues' verbal evidence, or HR provides docs, i.e. colleague states that still experiencing pain and cannot walk due to ankle injury, but according to HR, supplied evidence to OH, which actually is supplied by colleague to HR from their medical treatment. Colleague does not do anything to get better and recommended by OH is that colleague is still fit to return to work.
Nicky, sorry, there's just been a little addendum to that.
Okay.
That the colleague is still not fit to return to work.
Okay. So if I'm understanding correctly, how do we make a clinical assessment and decision? And what happens if there's a difference between what our advice is versus what the individual believes is, or that they're still continuing to feel that they're not able to return to work? So hopefully I'll capture this in my answer. So what happens is in an OH assessment, so we, as I said at the beginning, we take this as a story. So your side of the story comes in the referral along with any other information or advice you have. We then make an assessment of the individual. So in the case of a physical injury like the ankle you've suggested, we would run through some clinical questions with that individual to understand what their capability is. Obviously, if we're in a face-to-face scenario, then we'd obviously be able to see how they're actually functioning on said ankle in this case. If we're not, we can do video links if it's a relevance for their job. So in that case, we would take a history from the individual, we'd look at treatment so far, we'd look at treatment planned, we'd look at what you've done as a business to try and help that individual, and then we'd offer you our advice and guidance. And on some occasions, that may well be that this individual is fit to return to work in some capacity with recommendations of adjustments to their job. Said individual may not wish to return to work because they don't want to, or they're having a better time at home, or whatever the reason might be behind why they're not wanting to come back to work and go and get another sick note from the GP. Occupational health has the ability to offer you advice and guidance which can supersede that GP fit note. And if we suggest that they are suitable to return to work in some capacity with reasonable adjustments, then if taken to a court of law, the court would fall down on the side of the occupational health practitioner because they're a specialist in that area. In a case where they've come in, they've said how terrible life is, how they can't walk, they can't do anything, they can't even dress themselves each day, then the practitioner is going to be stuck and have to take some of that element at face value, unless, you know, there's anything else to prove otherwise. And often people will slip up in the questioning about what they can and can't do. So those are the kind of things that an OH practitioner is trained to hone in on. If for example, in the referral, you've sent in a picture of that person dancing on the table at some party that they attended, then that won't be something that we will get involved in. That then becomes a discipline issue and is for the management and your own internal processes to resolve and deal with, really. So hopefully I've covered what you were looking for in that answer. Oops, got another one. So someone's been off sick for over 5 months, diarrhea and vomiting as reason on GP notes, referred to OH a month ago, report returned saying that we need to wait for prognosis before OH can advise us. Individual is awaiting appointment but delayed due to COVID. Is there anything we can do? That's quite a difficult one. I mean, there are some illnesses where an individual can have diarrhea and vomiting and need a whole host of physical assessments and tests to be able to diagnose that. At the moment, we are in a challenging time with COVID because it has put quite an obstacle on all of the you know, kind of hospital services due to the people being in hospital with COVID. I think, you know, dependent on what a person does, there may be opportunities for them to perhaps work from home in that circumstance. I don't know, where we could get them back in some capacity whilst we await that final decision. Obviously, if a person cannot do that, then if they're going to the loo every 25 minutes or every hour, then it's quite difficult them A, to commute, and B, to be, you know, to perform in the environment that they're working in, and they would need close access to any, you know, facilities. So I think it's about probably in that situation, they may well have some sort of internal infection, or they could have the early stages of Crohn's, you know, IBS. So it is about investigations, but usually things like that do just die out naturally. So if it's a virus and they've been treated with antibiotics or not, the virus or the bacterium, if it's a bacterial-based infection, which would be when you'd use the antibiotics, would then kind of, it would just die itself out. So it feels to me like there could be some other underlying things within this particular case. There may be some psychological issues too, and often people present with physical issues when all the tests come back negative, and it's usually some sort of psychological. So in that case, what I would suggest you think about is whether there's an opportunity for this individual to work from home in any capacity at all. If not possible, obviously, there's not a huge amount more you can look at until they've got that diagnosis, or at least the toileting requirement is controlled in some way or other. So it's a tough one, that one. Next one, I have an ongoing LTS case, 6 to 9 months, long-term sickness, that is for anyone who might not know, I'm sure you all do. Autoimmune mental health is ongoing with minimal improvement from treatment to date. Attendance is still unpredictable and therefore constant team operational impact. We've made a number of reasonable adjustments, time and attendance targets, start finish times, tasks, duties. However, capability is still a concern. Specialist appointments keep getting delayed due to COVID. Do we refer to OH again or wait for the specialist appointment? 6 to 9 months is a long time, and most people, you would hope, would have had some input. At face value, you could do one more referral into occupational health and ask what the likelihood is of this person returning to work and in what time scales. And then you can obviously decide from a perspective of whether that's something you could accept as an employer in regards to that time frame of a likely return. Obviously, dependent upon what, again, your policies within are, whether you have any access for enhanced healthcare or anything down that line, you could actively encourage them to utilise that. But I think, you know, without a complete diagnosis or without any treatment, you know, you're within your rights, as long as you've been reasonable, which seems to be demonstrated in what you've written in that message, that you're within your rights to progress down your normal capability routes. It's a difficult one, particularly in the current environment with COVID, but I'd probably do another, dependent on when your last referral was. If it was in the last 2 months, then you're probably not going to get a huge amount of difference. But if it was a little while ago, then it's probably worth re-asking those key questions in regards to this person's likely capability in the longer term. Okay, sorry, this is follow up on EE. Saying too unwell to, I can't think what WFH means.
Work from home.
Thank you. Sorry, I had a brain drain there. Agree, think there may be more going on, but hard to communicate with EE. Okay, so I guess what might be useful in that situation is a case conference with EE, you know, with appropriate people on board, and explain to them the situation that you find yourself in. To be honest, there's always a question that crops up about whether people are fit to attend, and I probably should have put a slide in about that, to be fair, to attend meetings, and you often get those who want to avoid doing those meetings. And I think, you know, the criteria we use in regards to meetings is if someone knows what day it is and are compos mentis, then the likelihood is that they are fit to attend a meeting. We may put in some suggestions around some adjustments within that meeting, like taking breaks or allowing a friend or colleague to come along with them. So, you know, so with that case, I would suggest that you have a face-to-face meet if you haven't already, and just try and explain the situation, that you can't cope without them not coming back to work, and that, you know, without anything further, you will need to look at the capability side of things. Often that's the trigger to get people to be more open and transparent, and work with you. I know that sounds like tough love, but sometimes that's how we have to go to encourage people to get to the point where they open up and be honest with us. Hope that covered what you were asking. Anything else?
Got a couple of people that have said thank you, very helpful. So thank you, Nikki.
No worries. I was probably a bit quick, really, but I wanted to leave more room at the end for the kind of reality cases that people might be challenged with.
One more question's just come in. I'll just pop it over.
Thank you. Can we have a list of good questions to use? I'm sure we can share the ones that we put on our referral, Nicole. I don't think that would be a problem, would it?
No, that's fine. We can
share the slides, probably.
Share the slides, and we can have that, what I'll be doing after this, just for the benefit of everyone on here. You'll receive an email with a link to the recording, and I can also do, you know, add the slides as a file download that's got the questions on there as well.
I think I can see where you're coming from with that question, because sometimes it's like, what do I need to know? And I think part of like we said at the very beginning, you know, about thinking about what you want from this referral will also pose some questions for you. And I think the ones on that list are really quite good, even though I know they're ours, but I think they are quite good and do give some real pointers to managers to help them ask those questions. And I think, you know, where you've got quite unique roles or job specifics, that's where we also leave a bit of free text within our referral form to allow people to ask specific questions around, you know, that particular part of the role, because they will be unique to you as a business or to that person's employment.
There's no more questions in the Q&A. Got a few minutes left if anyone wants to pop any in. If not, then
yeah. And feel free at the end if you want to just give a bit of feedback. I'm more than happy to look at that and make sure anything I present going forward includes some of that as well. I've tried to think as broad as I can to share. Thank you, Sarah. Well, hopefully you got something new from that, and some of it just gave your brain cells a bit of a refresher, because unless you do these things all the time, it can kind of sometimes dry up a little bit. So thank you all for your attendance.
Thanks, Nikki. Yeah, we just got another one. Thanks, Carmen. Oh. Thank you so much. Very helpful. Yeah, thanks. Great session, Nikki, and thank you everyone for attending. And as I say, just keep your eye out for an email in the next day or so with the recording and a link to the presentation. Got a few more there. We've got some lovely ones. Alex, thank you. Thank you. Really helpful and useful. Thank you. Very informative. So well done. Thanks everyone.
Thank you. Thanks for your time, everyone.